Pain Management Basics for Palliative Care Providers by Quy Tran. Disclosure information. No relevant financial relationships to disclose. No honoraria or payment was accepted for this presentation, and all opinions are strictly my own. Objectives. Opioid titration, opioid naive versus opioid tolerant, opioid maintenance therapy and de-escalating opioids, opioid conversions, opioid side effects, and methadone. Let's start with clinical case number 1. A healthy 32-year-old woman breaks her leg while skiing. In the ER, she is in excruciating 10 out of 10 pain. Prior to admission, she was taking no medications. How would you treat her pain? Dose finding in opioid-naive patients in acute severe pain. We generally start with short-acting opioids, either morphine, oxycodone, or hydromorphone. Take into account the time to peak analgesic effect in order to find the appropriate dose. For oral, it is 60 to 90 minutes, and for IV, it is 6 to 15 minutes. This is the National Comprehensive Cancer Network Clinical Practice Guidelines in Oncology for adult cancer pain for opioid-naive patients. For our patient, we shouldn't aim for a target of 0 out of 10 pain, but we should monitor the patient as we titrate the medications, watching for sedation as this precedes respiratory depression. In this example, given that the patient is young and healthy, we could start with morphine 5 milligrams IV. If she were old or frail, we could start with the lower dose. Assuming we start with 5 milligrams, we wait 15 minutes and assess and ask how her pain is. If it's still 10 out of 10, we give a higher dose of morphine, i.e. 10 milligrams of IV morphine. Wait 15 minutes and assess and ask how her pain is. If a little better but still pretty bad, say 5 out of 10, we give the same dose again. We wait 15 minutes and assess and ask how our pain is. If much more comfortable, then that 10 milligram dose is a good dose for the patient. And after 2 to 3 cycles, if the pain is not improved, then consider an alternate strategy. The as-needed dose frequency is then based on the duration of action. For oral, it is 4 hours, and for IV, it's about 2 to 3 hours. So for our patient, we could order the morphine dose of 10 milligrams IV with a frequency of every 3 hours, PRN pain. What about a PCA? Well, there are pros and cons of a PCA. For pros, it can be used for severe pain. You can use it to rapidly titrate to the correct dose, and it allows for patients to feel like they are in control. For cons, it is not advantageous to use it if the anticipated opioid need is less than 24 hours. Patients who cannot understand how to use it should not have a PCA. There is a concern for use of PCAs by proxy, and PCAs are parenteral only. This is Table 7.1 from the book Demystifying Opioid Conversion Calculations by Dr. McPherson. It gives examples of starting an IV PCA with ranges for opioid-naive adults. Let's continue with case number 1. It is hospital day 2 for a young patient with a broken leg. Orthopedics has fixed her leg. We have been able to transition her pain meds to morphine, IR 15 to 30 milligrams, PRN, moderate to severe pain, with good effect. She mentions to you she hasn't pooped for 3 days. What do you do? Adverse effects of opioids. Common opioid-induced adverse effects include constipation, which is the most common, nausea and vomiting, sedation, dizziness, confusion, delirium, hallucinations, diaphoresis, and dry mouth. Less common are pruritus, respiratory depression, endocrine changes, neurotoxicity including seizures, myoclonus, and hyperalgesia, immunosuppression, and much more. In general, the rule is the hand that writes the opioid writes the laxative or does the disimpaction. There are a number of laxatives that you can use, including bulk-forming laxatives such as psyllium, which really does not help with opioid-induced constipation. There are also surfactants, including docosate, which doesn't also help and is being used less often. Stimulant laxatives are the preferred agents and include bisacodyl and senna. Osmotics include polyethylene glycol or Miralax, lactulose, and sorbitol. The combination of senna and Miralax is a popular combination. Enemas can be used, such as sodium phosphate or fleets, but you generally avoid this in older adults. Bisacodyl, mineral oil, and soap suds. And for those cases that are refractory, you can use peripheral opioid antagonists such as methotrexate. Let's return to case number 1. It is hospital day 3 for a young patient with a broken leg. She's been comfortable with morphine IR 15 to 30 milligrams PRN, moderate to severe pain. She has taken 3 PRN doses, about 75 milligrams of oral morphine, over the past 24 hours. The nurse pages you concerned that she seems sleepier than usual. What would you do? When to give naloxone or Narcan? Be cautious about giving Narcan. It is rarely needed. It can cause significant acute withdrawal pain and is not to be used for mental status changes. Just hold the opioid and let it wear off. The indications for using naloxone include respiratory rate less than 6 or an SpO2 less than 90%. But first, assess for other causes. To administer naloxone, the initial dosing is 0.1 to 0.4 milligrams IV q 2 to 3 minutes, up to 10 milligrams total. You could also dilute in a 10 cc syringe and give 1 cc at a time to avoid severe withdrawal pain. If the patient responds and they are on a long-acting opioid, then start a Narcan drip. If our patient is sleepy but arousable and breathing with a respiratory rate of 8, just stop the morphine and monitor. Let's return to case number 1. Our patient perks up about 6 hours later without intervention. A couple of hours later, her pain has returned and is 8 out of 10 in severity. You notice that her labs this morning were notable for a doubling of her creatinine. How would you manage her pain? There are a number of reasons for switching opioids. Intolerable adverse effects such as sedation or nausea, poor analgesic response despite aggressive titration, drug-drug interactions, a need for a different route of administration, a change in a clinical status such as malabsorption or renal failure, or financial or drug availability considerations. There are a number of opioid choices. Morphine should be avoided in kidney disease, but it's relatively cheap. Hydromorphone can be used cautiously in kidney disease, and the long-acting form is available but very expensive. Oxycodone can also be used in kidney disease, but potentially cautiously. The long-acting form is not covered by all insurances. Fentanyl can be used in kidney disease. The transdermal form has a special conversion table and is not a good idea to use in febrile patients and should not use in opioid-naive patients. Methadone can also be used in kidney disease, but you should monitor QTc and there are lots of drug interactions. Hydrocodone should be avoided in kidney disease. Codeine should also be avoided in kidney disease. This is the basic approach to converting one opioid to another. First, calculate the current drug's 24-hour dose. Next, use an equianalgesic table to convert to the new drug's 24-hour dose. Next, divide the new 24-hour drug dose by the number of times to be given per day. This is the new individual drug dose. Next, account for residual drug in system, cross-tolerance, and patient factors by decreasing the dose by 25 to 50%. You can decrease the dose even more switching to methadone. Or you can use the packet insert guidelines to switch to transdermal fentanyl, which already counts for cross-tolerance. This is a sample equianalgesic table to convert between opioid. A number of variations do exist. UCD Pharmacy also uses a slightly different table. For our patient who was taking 15 to 30 milligrams morphine IR as needed with good relief, we could change to Dilaudid 2 to 4 milligrams PO as needed given her renal failure. This is the math. 15 milligrams PO morphine divided by 4 equals 3.75 milligrams PO Dilaudid. With the 50% reduction, this is 1.8 milligrams of PO Dilaudid. You can then round the Dilaudid to 2 milligrams or even increase it to 4 milligrams PO as needed. Case number 1 continued. A couple of days later, your patient's renal failure improves, her pain is well controlled, and she is discharged with PRN pain meds in rehab. Let's go on to clinical case number 2. This is a 64-year-old man with a history of prostate cancer with mets to the bone. He falls and fractures his femur. He is in excruciating 10 out of 10 pain. His chronic malignant pain was often at a 2 to 3 out of 10 with the following medications: OxyContin 40 milligrams PO Q12 hours plus OxyIR 15 milligrams Q2 hours PRN, about 2 doses per day on average. How would you manage the patient's acute pain? This is dose finding in an opioid tolerant patient in acute pain. How much opioid was our patient taking in the last 24 hours? He was taking OxyContin 40 milligrams PO Q12 hours as well as OxyIR 15 milligrams Q2 hours PRN, about 2 doses on average. Oxycodone 80 milligrams basal plus 30 milligrams PRN equals 110 milligrams of oxycodone equivalents. This is about 165 milligrams of oral morphine equivalents using the prior equianalgesic table, which is about 55 milligrams of IV morphine. One approach is to give the basal medication around the clock and adjust the PRN dose. So the basal dose would then be OxyContin 50 milligrams PO BID. But what about the PRN dose? This is the National Comprehensive Cancer Network Clinical Practice Guidelines in Oncology for Adult Cancer Pain for opioid-tolerant patients. We use a similar idea as for opioid-naive patients, but the initial opioid dose depends on the patient's 24-hour use. We continue the basal pain meds. So for our patient using 110 milligrams of oxycodone daily in acute severe pain, we could start with 20 milligrams of oxycodone PO or 10 milligrams of IV morphine. What about PCAs for opioid-tolerant patients? A PCA for our patient is a good idea. To use a PCA, follow the following steps. As a reminder, our patient was taking OxyContin 40 milligrams PO Q12 hours with OxyIR 15 milligrams Q2 hours PRN, about 2 doses a day. Step 1. Replace OxyContin with the basal from the PCA. 55 milligrams of IV morphine daily divided by 24 hours is 2.29 milligrams IV morphine per hour. Since we are converting between opioids, account for incomplete cross-tolerance. The extent to which we do this can depend on how well controlled our patient's pain is. Since this patient is in 10 out of 10 pain, we don't have to adjust much. Perhaps go at 2 milligrams IV morphine per hour as the basal. Step 2. Calculate the demand or bolus PCA dose. Generally, start with 50% of the basal dose. It's about 1 milligram IV morphine bolus. Step 3. Determine the lockout or dosing interval. Generally, choose the peak effect, about 6 to 15 minutes, or about 10 minutes for most situations. You could extend the lockout or dosing interval if there are clinical concerns. For example, you can use 30 minutes. Here are some PCA pearls. The basal dose can be adjusted every 24 hours. It allows for patient to achieve steady state serum concentrations. Generally should be more conservative with basal dose changes. The bolus dose can be adjusted every 30 to 60 minutes and can be more liberal with these adjustments. The bolus dose can be anywhere from 50 to 100% of the hourly infusion. Let's return to case number 2. Our 64-year-old man with metastatic prostate cancer's hospitalization is uneventful and it recovers nicely. 8 months later, you see him at clinic. His pain on average is 7 out of 10, but he's doing okay. His spinal mets have progressed. His home opioid regimen is OxyContin 40 milligrams PO Q12 hours plus OxyIR 15 milligrams Q2 hours PRN, about 5 doses per day on average. How would you adjust his pain meds? What is well-controlled pain? Well-controlled pain generally means pain scores less than or equal to 4 and using up to 3 doses of breakthrough pain meds daily and able to do activities without much limitation from pain. Here are some principles of maintenance opioid therapy. Use extended release or long-acting formulation to provide background analgesia for control of chronic persistent pain controlled on stable doses of short-acting opioids. Provide rescue doses or short-acting opioids. Try to use the same opioid for long and short-acting needs, and allow rescue doses of short-acting opioids of 10 to 15% of 24-hour oral dose. Let's return to case number 2, maintenance therapy. What is the patient's 24-hour opioid use? He's using OxyContin 40 milligrams PO Q12 hours plus OxyIR 15 milligrams Q2 hours PRN, about 5 doses per day on average. This is a total of 80 milligrams basal plus 75 milligrams PRN for a total of 155 milligrams of oxycodone daily. Since he is tolerating the above but is having poorly controlled pain, we could increase the OxyContin to 80 milligrams PO BID, which is slightly more than what he takes already, and increase the OxyIR to 20 or 25 milligram doses, about 15 milligrams of daily use. It turns out our patient with metastatic prostate cancer can get palliative radiation to his spinal lesions. A couple of weeks after radiation is started, he notes an improvement in his pain. At home, he now takes OxyContin 80 milligrams PO BID and OxyIR 20 milligrams PO PRN, but hasn't required any in the past few days. How would you adjust his pain meds? How to know when to back off or change your approach. The patient experiences significant side effects, for example, opioid-induced neurotoxicity. You should consider a downward dose titration or changing your approach. The opioid requirement decreases, for example, with introduction of opioid-sparing coanalgesic or non-pharmacologic interventions like radiation. Decreasing opioid doses. If the patient has good pain control but is experiencing dose-related side effects, decrease the round-the-clock opioid by 30% but keep the rescue dose unchanged. If there is continued pain plus side effects, consider coanalgesics and decrease the around-the-clock dose by 30 to 50%. Alternatively, you can use opioid rotation, which is usually preferred. If there is good pain control and you anticipate an eventual discontinuation of opioids, decrease the around-the-clock opioid by 50% and continue dose reductions every third day until off. Rescue doses should remain available during the downward titration period. Slow down on dose reduction if pain becomes out of control, the patient is using rescue meds consistently, or the patient develops signs or symptoms of opioid withdrawal symptoms. And these may include restlessness, irritability, agitation, dysphoric mood, abdominal pain, pupillary dilation, lacrimation, rhinorrhea, goosebumps, yawning, sneezing, nausea, vomiting, or diarrhea. This is the final topic of methadone. Methadone is structurally unrelated to other opioids. It is a racemic mixture of two isomers. The D isomer is the NMDA antagonist and also inhibits norepinephrine and serotonin. The L isomer is the one that is a mu and delta opioid agonist. It has high lipophilicity, and there are two half-lives, so it acts as both an IR and an SR. The alpha half-life initially is 4 to 6 hours, then 8 to 12 hours with repeated dosing. The beta half-life is 5 to 130 hours with an average of 22 to 27 hours. Opioids can be converted to methadone using the reduce and replace method. This slowly adds methadone while tapering the other opioid. First, you would calculate the total oral morphine equivalents. Next, using a conversion table, convert the oral morphine equivalents to 24-hour methadone doses. On day 1, the total OME is reduced by 1/3, and 1/3 of the 24-hour calculated methadone dose is started. On day 2, the total OME is reduced by another 1/3, and another 1/3 of the calculated methadone dose is added. On day 3, the total OME is discontinued and methadone is increased to 100% of the calculated dose. This is an echoanalgesic table to convert from oral morphine equivalents to methadone. This is the Ayan-Rindy method, but other variations do exist. Clinical case number 3. A 55-year-old man with a history of pancreatic cancer with mets to the liver, lungs, and brain. He has persistent cancer-related pain despite escalating doses of opioids. He has been taking the following medications: OxyContin 120 mg PO Q8 hours plus OxyIR 40 mg Q2 hours PRN, about 4 doses per day on average. You wish to convert to methadone to take advantage of methadone's multiple mechanisms of pain control. How would you convert the patient's medications? Using the reduce and replace method to convert. Recall that the patient is taking OxyContin 120 mg PO Q8 hours and OxyIR 40 mg Q2 hours PRN times 4 doses daily. Step 1. Calculate total oxycodone of 520 mg per day and then convert to 780 mg of oral morphine equivalents using prior tables. Step 2. Use the Ayan-Rindy table with a conversion of 12 to 1 or 65 mg of methadone as calculated. Step 3. Day 1. Oxycodone dose is decreased by 1/3 to approximately 340 mg per day of oxycodone, or starting 1/3 of the methadone, or about 22 mg or approximately 8 mg TID. Step 4. Day 2. Oxycodone dose is decreased by another 1/3 to about 170 mg per day, or starting another 1/3 of the methadone, or about 44 mg or approximately 15 mg TID. Step 5. Day 3. Oxycodone is discontinued and methadone is started at 22 mg PO TID, or can be rounded to methadone 20 mg PO TID. Step 6. Select a PRN dosing, which could be methadone 5 mg PO Q4 hours PRN or OxyIR 50 mg PO Q4 hours PRN. Those are the basics of pain management for palliative care providers. In this talk, you have learned about opioid titration in opioid naive versus opioid tolerant patients, opioid maintenance therapy, and de-escalating opioids. You have also learned about opioid conversions and opioid side effects. And you also have a basic understanding of methadone. Thank you for listening to this presentation by Dr. Quy Tran.